I will screw it up.
Okay, so let's talk about ports.
Ports.
Okay.
This is where aliens come through.
So,
Where what?
Aliens come in and out of the ports.
I pushed it back up against the wall here because the easiest part, I think, for you guys to access them is probably when you get them on the stretcher.
Yeah.
Because if not, if they're sitting and you start to push on it, then they lean back and that causes all kinds of.
Can you move to the other side where they can see?
Yeah, causes all kinds of problems. So, of course, these are some other central lines, and you're going to see them also, but we're talking about ports right now. It's usually in the upper chest. All right, so you're going to see ports mostly in cancer patients or anybody with like a long-term disease that has to have long-term IV access. So most of them are going to know how to take care of their port. If you have a question, or ask them, if it doesn't draw blood, ask them, is this normal to not have a good blood return? Because that's possible that it could function and not have a good blood return. So I think laying flat would be the easiest way for you to access it. So once they get on the stretcher, when you lay flat, it kind of pokes up a little bit better too, so you can see it.
Okay.
So once you've already got them kind of strapped down, then you can start working on their
I run
port.
into a problem of them not wanting me to access their port.
Really?
Yeah. Like, I don't know if they're just uncomfortable and don't realize that we're able to now, but they're like,
Probably.
they're like, can the ER just do it when we get there? Yeah. Because obviously, unless I need a port, then obviously I talk them into it. But if it's just something that at that time that doesn't really need access, I'll wait. I guess I don't know if they feel like it's more a sterile environment here in the ER.
Probably, and they've been told, no, don't let just anybody access your port because you have to be trained to do it correctly.
Right.
So it's okay to say, well, we actually got training from, the ER trained us on how to do it. Try that.
But that's I've ran into it quite a bit.
Some of them still have some good veins, but a lot of them have
and a lot of them like you just start an IV instead.
Yeah.
So a lot of times some of them just don't like their port to be accessed.
Yeah.
Well, it's scary. I mean,
that's a central line.
Yeah. Yeah, and you have to treat it like that.
Sorry about that. It's the wonky internet. So I asked Rachel to pause. You guys didn't miss anything. She's starting up again.
Okay, so the first thing we're going to do is clean with ChloraPrep. If you just squeeze those until it pops, when you put a little bit of pressure, it starts to come out the little swab. So you want to clean in a circular outward motion.
Is betadine appropriate too?
Yeah.
Okay.
So you don't want to clean and come down here and then come back up here and clean, because then you're rubbing the bacteria from here up here. So just one good circular outward motion, and then let it dry. So while it's drying, then you can get your equipment ready. So here's some different size needles.
Should you have sterile gloves on for this?
Yes. I'll tell you when to put them on though. There's different size needles. So
what is the typical size? Because I know
typical size is 20 gauge 1 inch, and I only brought one of those, which is what we were going to use to access.
We carry 1.75 and 1.5.
Well, yeah, 0.75, so 3/4 inch, 1 inch, and then 1.5. So if you have a small person, which we do have a few kids around here with ports.
Oh.
We normally would want to use, unless they're adult size, we would want to use the 3/4.
Okay.
The normal one is a 1 inch, but if somebody's really big, or there's one surgeon in Mountain Home that likes to put the ports lower down a little bit more in the breast tissue, then they're deeper. So you'll have to have a 1.5 for that. If you can't see it stick up when they lay down and you have to feel for it, you're better off to get the longer needle, because it's not going to hurt anything. It's just longer. The most important thing is to never use any other kind of needle but a non-coring needle. No butterflies, no IVs. It means the needle is like cored out. Because if you use a regular needle, you take a risk of a little piece of that silicone coming out and you flushing it into the patient. So that's been an issue here lately with a few people. So you can't just use any kind of needle. Just because it's a needle, you can't put it in there. It has to be a non-coring needle.
But all of these should be non.
Yes, they all are.
Okay.
All of these
I don't know why
right
would you want
angle.
to- Yeah, because they're angled. I mean, why would you want to use that?
Well, sometimes people think they can just draw blood like with a butterfly and put it in there and draw blood and then pull it out. But
This was the conversation we had
Don't
a
do
couple
that.
of weeks ago where a nurse was saying, okay, all right.
you can't do that because, well, first of all, you're taking a chance of injecting something into the patient. And then second of all, you can't flush with heparin. You're not flushing anything through it. So you're pulling blood back up into that line and then you're just leaving it there. So then that fibrin's going to start to clot and then they're not going to be able to use their line, or it's not going to draw blood back. So never ever put any other kind of needle in there. Okay, so we've swabbed that. It's drying. Go ahead and open you're going to be as sterile as possible. You're not going to be 100% sterile. So
Don't cough, don't wipe your nose.
right. So this is how I do it. I'm getting my needle ready first. So I'm not touching the needle. I'm touching the edge right here, the little cap. Actually, you probably want to leave that here because you might need that if you're going to hip lock, if you're going to just lock it and not run fluids through it. Go ahead and prime it. You see a couple drops come out. Put your sterile gloves on. Does everybody know how to put sterile gloves on?
We could probably use the review.
When you open this, you've got a sterile field when you open this. So there's little fold right here. Put your fingers under the fold.
Where?
There's a little fold right here.
Uh-huh.
So don't reach in. Just put your finger right under that fold and you can kind of pull it apart like that. Now you've got a bigger sterile field if you need that. You can get it to stay right. So get it on the edge here. Put your one glove on.
Yeah, I've been doing it from.
And then your fingers, I don't know if you can see it, but your fingers go under this other edge.
Because it's sterile.
Right, because it's sterile and you don't want to touch the fingertips at all. Okay.
Classes like this.
Now. Now we're going back to our port needle.
After I've accessed a couple of them, I'm a lot more comfortable, and they're super easy.
Oh yeah,
Super.
they're way easier than the hard IV.
Yeah.
Okay, so now you've already got your syringe on. It's primed. It stays on. Got your needle, your little butterflies, so you can hold on to that. All you do is pull this little cap off. It comes straight off your needle. Can you see the needle? Can I see the needle?
Yes.
Okay. It's a right angle needle, and it's a non-coring needle. That's why you've got that little tip pointed down like that.
Oh.
Can you see it?
Mm-hmm.
See how it's pointed down?
Yeah.
Okay.
So that's intentional.
Yes. Okay, so you've already felt your port. You know where it's at. You feel the edges. You've already done all that. So you're going to hold your port steady, and you're going to, it's about the size of a quarter.
Yeah.
Maybe a little smaller now, a lot of them are, but you just hold two edges like this. So you're going to hold it still from moving back and forth in the subcu tissue or fat, whatever. And you're going to aim for the very center of it. And you're just, I kind of hold it with my fingers like that. But you hit the very center, and you don't want to like mess around. You want to push it through quickly, but you feel it start to hit the port. And you'll feel the needle hit the back of the port.
And that's what you want.
And that's what you want. So you can't push it too hard, you know, so it's gonna, sometimes you're pushing and you do hit the back of the, you know, you feel it like it's hard, but it doesn't hurt them, and that's a good thing because you know you're where you need to be. So you should always try to aspirate first, and you should get a blood return, but you don't always get a blood return. You don't want any bubbles around here. If you're starting to push fluid in here, there's a cup back there, but
It'll be like an IV.
it's yeah. I saw one time somebody came to me from the ER with a whole unit of blood under their chest, in their chest.
From here?
No.
Okay. So it wasn't one of our groups. Okay.
No, I was working the floor and they came from the ER like that. Like somebody had started the unit of blood and just, they were checking their vital signs, but they weren't looking at the site. That's still an IV and you still have to look at it. You can still have extravasation there. Pooling of fluid. So you still have to look at it when you're doing your IV assessment.
So you want to, let me get my processes straight. You want to aspirate before you administer heparin, or do you want to administer heparin then?
Well, right when you access, you want to try to aspirate first. Mm-hmm. If you get blood, that's great. If you don't, then you want to go ahead and start to try to flush with your flush that's on here, just easily. We're going to pretend like it's flushing easily.
I've seen it. We're going to say it.
So as long as it's functioning properly, you don't see any of those problems around it, then you're going to just hook your fluid up and let it run just like we would any other time. But you're going to keep a monitor on this. So while that's doing that, I didn't bring any kind of kit with me to a dressing, but you should have a dressing like a Tegaderm kit in your
large Tegaderm.
Yeah. Mm-hmm. So that goes on over this, and there's actually like a little notch in the Tegaderm that the tubing will come out of, and it will hold your tubing in.
But isn't there a disc that goes underneath that also?
Mm-hmm. Yeah, there is. There's a little circular disc if you can get it between the patient's skin and the plastic right there of the needle. I remember to put them. Mm-hmm. Trying to think of anything else. The only other thing is you should only put saline through it unless you're going to pull the needle out. And like, I guess that could happen to you. You know, you could be on the side of the road and access somebody's port and they decide they don't want to go anywhere, you know. So just always make sure at the end before you pull it out, the last thing that goes through it is a 400 units of Heplock.
Is that the whole thing?
Yes.
400 units.
Yes, that's still our policy as far as I know. Some places are changing that, but as far as I know, we're still doing Heplock.
Is it just like a regular push?
Mm-hmm.
Like
just a regular push. It's a flush. But another thing that you can do is as you're flushing it, at the very end of it, if you clamp it while you're flushing it, it keeps positive pressure in there and it keeps that Heplock in the line. Okay. So that's better if you can do that. So you've drawn your blood and the patient says they don't want to, oh, I don't want to go to the ER, I'm fine. So you've got still your syringe, or if you need another one, go ahead and grab another one and flush with 10 cc's of saline. And then at the end, flush with your Heplock. Okay. But another thing I was going to talk to you about, I'm sorry, I'm a little all over the place, but so you don't have to put a Heplock cap on this. You just have to make sure anytime you open it, you have this clamped if you're going to change syringes. Best practice is to hold it down. You don't want to hold it up because you don't want bacteria falling on it.
I thought it was a sterilization issue.
Or sideways. You just don't want to hold it up if you can.
So it's better for it to hang down instead of lifting it back up.
Yeah, just because you don't want bacteria falling on it. Is there a Heplock?
Not to have the Heplock cap on it?
I do, but if you're afraid that you can't remember to clamp it every time, then put the Heplock cap on.
You guys can always take it off.
Right.
Is there anything that can't be pushed through a port, like any sort of med that you don't want going through that site?
Mm-mm. No, the only thing is contrast, like IV contrast. And if they have power ports, a lot of the new ports, when you feel them, you feel 3 dot. You'll feel it. It's a little bit smaller and it's a little bit more triangular, and you feel 3 dots, and those are power ports. And that means they can have IV contrast pushed through.
Okay. So you flush,
Yeah.
or you aspirate and you flush with saline.
Right.
You push the heparin, you flush again.
No, you only put Heplock in if you're going to de-access.
You only what?
You only put the Heplock in if you're going to pull the needle out. Otherwise, you shouldn't be using heparin.
Okay.
Only saline.
Only saline. Okay.
So saline should be, if you have IV push meds, you're going to give saline, your meds, saline again. Always in with saline because you don't want that large amount of the medicine in the tubing. The only time you should ever use Heplock is if you're taking the needle out.
Yeah, I've been doing it wrong.
Okay. It's not hurting anything.
No, because I went on the floor the other day to help out because I needed something, and I pushed morphine, I think, and then flush it with the flush, and then flush it with the heparin and block it. But there was access to it was still on there.
Okay. I'll talk to them about it.
Oh wait, I don't think it's a port. Never mind, it was central.
It was a PIC line?
Yeah. Is it still the same?
Still, I don't think you should be given that much Heplock through it, so we need to check on that.
Okay.
Now, sometimes they'll say, even when they say we have orders to flush the PIC line once a shift, like if we're not really using it, we'll flush it once a shift, but we're not flushing it with heparin every shift. So it's just saline. So we need to ask them about that, talk to them about that. I will. Because as far as I know, Heplock should only go through when you're de-seeing a line.
Well, that makes me wonder, because we have the capabilities to access, but technically in our protocols, we do not have protocol to remove it.
Okay.
So do we need to remove the heparin off?
I think we need to get a protocol, because you're going to get in a situation where you're going to access somebody's port and then they're not going to want to come in, or they're going to die in their DNR or something.
Yeah.
And you're going to have to de-access it out there.
Okay.
So we need to get that on the protocol. That's not going to happen very often, but eventually it will.
Yeah. No.
So are you running into people with PIC lines? Probably more than ports.
On transfers, yeah.
Mm-hmm.
That's going to be my next question. But before we move on to that, I don't remember now what it was. Already gone. 15 minutes ago. Yes. So we'll go ahead and move on. You have the dual lumen, and then you have the triple lumen.
Mm-hmm.
What's the difference between the two?
They're just so what's implanted, or what's the word I'm looking for? The part that's actually in the vein up here they just come out at different. They're like tiered. They come out at different areas. So there's not really any difference. They like inside when you look at it, you've got 2 tubes right here. They don't stop. They're not the same length. One of them's shorter than the other.
So is it the equivalent of starting 2 IVs in the same thing?
Yeah.
Okay.
Or 3.
Okay. Interesting.
And I don't hardly ever see these anymore. That's a Hickman catheter. So one thing though, you want to be sure that if somebody has a temporary dialysis catheter, that you're not accessing.
So
When I was at Baxter, we didn't never do that.
Here, for the PIC line?
Care for the PIC line.
Mhm.
You should just make sure EMS that it's got a dressing and it's covered here. And they should all, again, they're used to having that, so they're gonna know. It's kind of like, it's still a central line, but it's kind of like the port. You're just gonna aspirate first and then flush.
Does it matter which one you access?
No,
Either one's good.
Yeah.
Even with the triple?
should be okay.
That's a little daunting.
Sometimes,
It's intimidating when you get patients.
Well, because I've heard somebody
Yeah.
says you have to do this color because you can't do this color.
Yeah.
I've heard that too.
Yeah.
I don't know. I think they're making it. I think they're
Two.
just so you can have two lines, like so they can have multiple things going at
When
once.
you
Oh, okay.
can't run the same med through the same.
Yeah, if they're not compatible, because that's why if they're not compatible, that makes sense really sometimes to me. But if one stops here and one stops here, then it's giving it a little bit of time to mix in the blood before they're
Other than
mixing in your tubing.
So same thing with heparin. It doesn't need heparin every time.
No,
We won't.
I would have to look at their protocol, but as far as EMS, no, you would just need to put saline through it. When we have orders to flush it once a shift, it's saline.
Do I ever draw back on the PIC line? to
Mhm,
make
you
sure it
can draw-
works?
yeah.
Okay, so I
Yeah.
draw back and then I would flush it with saline and then I
Yes.
would give my Zofran.
Yes,
Can you
And-
draw a line?
yes,
You can.
absolutely.
you have to what, waste 10?
Yes. And the same thing with the port, you need to waste 10. The reason you're wasting 10 is because you're flushing it with this, you're going to waste whatever you put through it. So
Yeah.
you're going to waste 10 because you're putting this 10 of saline through.
Gotcha.
So what I do to make it easy for me is I just flush this and then pull back with this syringe right here, and then that's my waste. This syringe looks a little different, so I'll just it's one less syringe you have to, one less time that you have
use
to.
the same one you flush with.
Mhm.
Waste.
Because if I just flush with this 10, then I can just pull back right there and get my waste and then get another. And that's one less time you can have to have that open, that system open.
So I know with the regular IV, you have to be conscientious about pulling too far back and not flattening the vein. Is there that concern with either
You
of
can-
the port accesses?
Yeah, you can do that. If you're not getting any blood return with it, that happens. It like pulls it up against like the side of the vein. And then, so the biggest thing that helps me is if they're laying down, which if they're not, I'll have them lay down or lay
So
back.
fine.
So,
Okay.
so if you're already like that, then that's better. But, you can have them take the arm. You can, you can have them take the arm side that is on the same side as the port and move it up and down like this. Helps.
Really?
Yeah. And you also, if you take your fingers, a lot of time you can see the tubing come up here. So if they're laying down, it's a possibility it's just a little kinked right here. I have them do their arm first, and then I try to feel the tubing, and you can just put your fingers like that and you can feel it, and then kind of pull down on it a couple of times. Sometimes that helps. And then you can also have them turn their head face away from you and cough. And while they're coughing, sometimes that'll let that release. So you can aspirate while they're coughing, and sometimes you can get a blood return like that.
So first with on the arm, and if that doesn't work, cough.
Yeah. You can also kind of feel the tubing. If it's kinked a little bit right there, you can kind of pull it down.
Manipulate
And
it.
sometimes that helps, yeah.
Wow.
But once you start working with them, they are way easier than if somebody's got a really hard IV. Because all you have to do is clean it. And I've been at the clinic before when I didn't have all those supplies, and I used an alcohol swab and clean gloves, seeing patients. I've only ever seen 2 ports infected. And one, they were accessing it themselves. So,
Oh. Non-sterile.
yeah.
I have a question. So what's the difference between chloroprep and an alcohol I know there's a benefit for it, but I don't remember. What it is.
Just another cleaner, I think. It's got alcohol in it.
Like the oxivir and the Cavi wax, gonna give you cancer and.
I've seen one person allergic to that.
Oh, really? Oh.
Where
The
does that make
chloroprep,
that?
but that's not going to hurt anything. And if you're stuck in a ditch and you got an alcohol pad and that's it, wipe it off good.
I had an EMT student ask me that. That's a great question. I don't know the answer. But I know that floor preps are slightly better for IV access than alcohol preps. I don't know.
Yeah, because it's got alcohol in it, but it's a dual, I guess, cleaner because it's got alcohol and then the chlorhexidine.
Oh, okay.
Okay. Y'all want to access it? Okay. All right.
Look at the brown fins this morning. Look at that.
Yeah, it's chilly in here, isn't it?
Is it? Pretty cool. I guess when it, feels like -7 outside, the spring finally cool down. First one I tasted chasing dog, it's cool.
Yes, I threw away the little piece over the. Okay.
And she's,
Here's the little piece. I thought we could actually flush it, but when I was trying to flush, I couldn't get a. Oops, that's real clean now.
It's just like in the back of a truck.
Yeah.
After stuff ends up on the floor anyway.
Oh, okay.
You know who's right.
I tell you, 9 times out of 10, it never fails. I'll get
Well,
all
you're
my
right.
stuff set up for an
You're
IV.
the only one.
I'll
who's
have my
crossed from
oxide
it.
laid on the patient. EMT is doing their thing. I'm not paying any attention. They're not paying any
Really?
attention. And that sheet just goes right over the top of the oxide every time. Every time. And I'm sitting there going, oh,
On 4 lead.
yes,
There it is.
yes, yes.
My thing that never fails is when I go draw blood, my blue tube always disappears. Just my blue
I would
one, every
never
single
say-
time.
And say yes.
Yes.
And I would go ahead
And
and
I
have
always
it clean
think to
first and
myself, they
circular
really
motion.
know
Yes.
when I actually started.
Gonna push it against there for you.
Yes, actually,
I figured they did.
because
Yep.
of the
And then I would put my
chemicals that
servos
are in the
on
bottom of it and stuff like that.
Mhm.
Yeah, it'll mess with the
on.
plyboard.
the other on.
If you draw
Yeah.
before.
I usually at
before
least
that
open
one.
the package because
Okay.
Then-
Package won't be sterile.
yeah.
Okay.
And I know it's not possible to stay
You know,
completely
we can
sterile
use
because you're
lavender.
touching this patient with this hand, but this one always is.
Okay.
Seriously,
All right.
And
So
give us
then I would
reasons
pick up
why.
the wings
just because
here.
I would actually like to know.
Well, first you're gonna want to put your
You
syringe
like
on
Okay.
why don't we- And
and go ahead and prime it.
that always,
Or it sounds very safe.
Good.
Yeah.
mashed
Shame.
potatoes. I'm just curious.
Last time I fought for lunch.
I ate it though.
All right.
Your daughter.
Oh, she didn't, that's right,
Yep.
because it was at the ball game.
Yeah.
Yeah.
I did try eat it. I don't know Cypress.
Yeah.
You hiding goodies over here.
She brought it, I forgot about it.
You said this was straight.
Yes.
Thank you. Oh my gosh, it's actually a
I
regular
wish you could
popcorn.
feel it. It was a little bit lower
And
than
that
what I
was
felt. It
bad.
was a little,
Well, I'm sure it was in bags first.
but I did feel it hit the
It's
back of it.
It's too
So
black rock.
looks like you did. Looks like you got it.
I thought
Then
it was
that's
bags.
good. So you're gonna come with, so you can aspirate first and then try to flush and it may run down the wall, but if it lets you flush it. It wouldn't let me.
So I was gonna bring home
And
my
then I
text
would
message.
just-
Are you
Yes.
bringing it tomorrow?
And always clamp it before you take the
breakfast.
syringe off.
Okay. That way it's not open.
Yeah. And then you can put your Heplock cap. You've got a Heplock cap in that little kit
Excuse me,
in the ambulance, so
Good
that's
girl.
probably best for out on the field, I would guess. Yeah.
Oh, very appreciative.
Yeah.
Yes.
But then you can hook up whatever you want to it and it's a functioning.
I mean, I didn't.
Oh, cool.
I know, it's
So used to
easy.
hear for you.
It's easy.